we're going to start our first lecture with a couple basic concepts and terms that are going to be important as we go through this course. The first of these involve the way that we break down the periods of human development. And as we'll see, these periods do to a certain degree mirror the trimesters of pregnancy. The first part that we're going to talk about is gametogenesis, which actually, of course, occurs before conception. And this is the process of forming eggs and sperm, and we'll go over that in our next lecture. The next period is the period of the egg. And the period of the egg, in general, begins with fertilization, so the meeting of sperm and egg, and goes through about the second week of embryonic development, which will take you from a fertilized egg to a zygote to a morula to a blastocyst, and once the embryo reaches the blastocyst stage, it can then implant in the wall of the uterus. And that action of implantation is generally considered to be the end of the period of the egg. The borderline between the period of the egg and the period of the embryo is a little bit fuzzy with a certain amount of disagreement, but on average, the period of the embryo would begin roughly week 3, so the third week of embryonic development, and continue through the 8th week. During that time, you're going to see development of extra embryonic structures. So that would be things like the placenta that support the baby but are not the baby. Gastrulation, which establishes the basic germ layers and body patterns. So we see the body plan emerge in the major axes of the baby's body. And then the beginning of organogenesis, the development of the organs. The last period is the period of the fetus, and it goes from roughly week 9 through birth. And a lot of that time, which is the bulk of a human pregnancy, is actually spent in growth and maturation, and not so much in the forming of specific structures. So what we're showing in this table here is this early first 2-week period, the period of the egg, followed by a several-week period of the embryo, and then finally the fetal period. Now, these periods become critical because insults, teratogens, medications the mother might take have different impacts based on when they occur in the pregnancy. Now, in this particular chart, the way that this is coded is each of these bars represents one major organ system, with the darker gray section being the most critical period, the period during which you might see birth defects, major birth defects, occur as a result of an exposure, whereas the light blue part refers to a less critical period during which you might see more minor kinds of birth defects or issues with the growth of the organ system. Now, the first part, this all or none period, is actually really important. So during that first 2 weeks of embryonic development, you can't actually cause birth defects with exposures or other kinds of insults. You either cause miscarriage or the baby recovers altogether. Okay? You really can't do anything during that time period that would produce a lasting birth defect. It's all or none. And that's really important because many, many women don't know they're pregnant until they miss their first period, which is well after quite a bit of embryonic development has occurred. So you can be very reassuring to those women who find out shortly after they've missed their first period that any of those things they might have done during that very early stage of pregnancy are unlikely, and in some cases impossible, to have caused birth defects or other problems for their babies. Now, the age of the embryo or the period of the embryo was quite different. During that time, exposures can and do cause birth defects, and the kinds of birth defects they cause depend on when the exposure occurred and how that particular exposure affects each organ system. Okay, and as we'll talk about later on throughout the semester, there are exposures that can have a significant impact on one organ system while having no impact on another. And a good example of this, just to sort of leave us with here, is the idea of Paxil. Paxil is a very popular antidepressant. It's in the SSRI category. It's very effective in treating depression, and studies have shown that it may cause certain kinds of birth defects, including heart defects. But when you look at a chart like this, you see that the development of the heart is largely complete by the end of 8 weeks. So a woman who relies on Paxil for good mental health could theoretically stop her Paxil when she finds out she's pregnant and then restart it after the critical period of heart development is complete, which for many women is much more preferable than continuing all the way to the end of a 9-month pregnancy before restarting their medication. Now, of course, these kinds of periods that we talked about, period of egg, period of the embryo, period of the fetus, refer to the development that's going on with the baby. But when women talk about their pregnancies and couples talk about their pregnancies, they're generally talking about trimesters. Okay, so the average human pregnancy is roughly 40 weeks in length, although of course there's a great deal of variation. Any baby born after 38 weeks is considered to be full term. Okay, so a baby that has completed all of its development. Once you get past 42 weeks, and most pregnancies will not extend that far on their own, but on occasion they do, and the risk for stillbirth does increase after 42 weeks. So most OB providers, be they medical obstetricians or midwives, will at that point discuss inducing the pregnancy to end it before the risk of stillbirth increases. Now, certainly there are babies that are born preterm that survive and do well. About the outer edge of viability for humans is 24 weeks, but at that point there is a significant risk for long-term complications for the baby as a result of having been premature. Now, the periods of human pregnancy are divided into trimesters, and they're roughly equal in size. The first trimester extends from week 1 through the end of week 13. Now, again, some people end the first trimester at 10 weeks, some at 12, some at 14. By the time you get to 14 weeks, though, most everybody agrees you're into your second trimester, which usually goes from roughly week 14 to the end of week 27, and then the third trimester extends from week 28 through the birth. Now, the idea of calculating gestational age can be a tricky one for pregnant women and even for some medical professionals to grasp, okay? Because when you're calculating gestational age, it's done based on the number of weeks since the first day of the woman's last menstrual period, okay? The last menstrual period, of course, occurs on average 2 weeks before conception. So when a baby is conceived, according to gestational dating, it's already 2 weeks old, okay? Makes very little sense to people once they start to think about it. But in reality, it's much easier to track the first day of your last menstrual period than it is to try and track conception date, which most women don't know. And so we've set up the system this way. Doesn't really mirror embryonic development, but it's much easier for medical professionals to use. Now, of course, not every woman knows the first day of her last menstrual period, or LMP, and so in those cases you can do an ultrasound in the first trimester to measure what's called the crown rump length, which is the distance from the top of the baby's head to the rump, to the baby's rear. Okay. In the first trimester, that is a highly accurate way to date the pregnancy, as babies are all almost exactly the same size down to the day. Okay. By the time you get into the second trimester, and certainly into the third, the size of the baby begins to vary, and you start to see what are called constitutional differences in growth. And the idea there is that small babies tend to come from small parents and large babies tend to come from large parents, but in the first trimester, they're all, on average, the same size. So our next topic are body axes, okay? And this is a way to sort of describe the orientation of the body, or the orientation of a birth defect or body system to the body. Now, the axes in the embryo or the fetus do mimic those in the adult, although the terminology is occasionally different. And knowing the body axes can be really useful when you're describing birth defects, and sometimes critical if you're trying to figure out that what you're reading about in a textbook, are they talking about normal anatomy or abnormal anatomy? Now, the first body axis in the embryo or fetus is the dorsal ventral axis. In the adult, it's called the anterior posterior axis. Basically, this is back to belly, and if it helps, think about the dorsal fin of a shark or a whale. That's on the back. The opposite of that then would be the belly. The next axis is the cranial caudal axis. In the embryo or fetus, in the adult, it's called superior and inferior. This is essentially head to toe. And again, this one's easy. Cranial, cranium, head. The opposite of that, of course, would be toes, or in this case, the caudal region, which is in reality your tailbone. But this axis describes sort of the orientation from head to toe. Then you have medial lateral, which is the same terminology for the adult and then for the embryo or fetus. This is right and left. Okay. And the last one is proximal or distal, which is a little bit trickier because the idea here is that proximal refers to things that are close to the body center, whereas distal is distant from the body center. But of course, it can be distant from the body center in any direction. Oftentimes, proximal and distal are used to describe things like limbs, where the shoulder would be proximal and the fingers would be distal. Another helpful way to describe the body is with section planes. Okay, these are essentially cross sections of the body in various orientations. The terminology is the same for the embryo, fetus, and the adult. And these are really useful when you're talking about ultrasound imaging, so prenatal imaging of the baby, autopsy reports, things of that nature. So the first section plane is the transverse plane. Okay, so this is shown in the image here in figure C. And essentially this cuts perpendicular to the cranial caudal axis. So it separates the baby's head from the baby's rear, or the person's head from the person's rear. The next is the sagittal plane. This one cuts parallel to the cranial caudal axis, and it's going to divide the body into right and left halves. But there are sort of different ways to do that. You can divide it exactly equally, which would be mid-sagittal, or you can favor one side or the other, which would be parasagittal. Now, a mid-sagittal section is going to cut down the midline of the body, which is exactly what it sounds like, exactly down the middle from head to toe. And the midline is an important concept in describing body structure, and we'll talk about it a little bit more in a minute. The last section plane is the coronal, or sometimes frontal plane. Again, this is going to cut parallel to the cranial caudal axis, but instead of separating left and right, this one separates front and back, or dorsal ventral. Now, a couple more terms that are really helpful when you're talking about the location of body structures. Unilateral and bilateral. So basically, these are terms that we use when we're discussing body systems or organs that are paired. So things that you have on one side and then on the other. Okay? So unilateral would talk about something affecting one side of the body or one of a paired set of organs. So for example, you have two kidneys. You can be born without one of those kidneys, and that would be unilateral renal agenesis. If you're born without both of your kidneys, then that's bilateral renal agenesis. The other location term here has to do with preaxial and postaxial, and these are terms that are most often used to discuss the limbs. So in this case, the axis in question is sort of the length of the limb, so for the arm from shoulder to fingers. Preaxial would refer to the thumb side. Postaxial would refer to the pinky side. Okay, and this is an important distinction because postaxial polydactyly, so duplication of the pinky or an extra finger on the pinky side, is actually relatively common. While it can go along with various genetic and environmental syndromes, it usually doesn't, and it can run in families as an isolated birth defect. Whereas preaxial polydactyly, duplication of the thumb, is a lot rarer, more likely to be associated with a birth defect or syndrome, and a little bit harder to treat. So we'll go through a couple examples just to use those terms. First, for anterior and posterior, a great example for this would be the placenta. So the placenta, as we'll see in later lectures, can actually attach anywhere in the uterus or occasionally on the cervix. But knowing where the placenta is a very helpful landmark, particularly for ultrasound imaging, and also helpful to obstetricians and midwives when caring for pregnancies and delivering babies. So placentas are usually described as being anterior or posterior, with posterior being sort of at the back of the uterus, the wall closest to the spine, and anterior being at the front of the uterus, or the wall closest to the mother's belly. Next, circling back to this idea of clefting and bilateral versus unilateral. So The first picture here is of a child with normal facial anatomy, and the second two are a child with various forms of cleft lip and possibly palate. Okay. Now, most clefts of the lip extend down from one or both nostrils. So they're generally shifted to one side or other of the philtrum, which is the groove that runs from the bottom of your nose to the top of your upper lip. And clefts can be unilateral or bilateral, so they can affect one side extending down from one nostril, or they can affect both sides extending down from both nostrils. A unilateral cleft is much less likely to be associated with a genetic syndrome than a bilateral cleft, and that makes a certain amount of sense. If it's randomness that's causing it, you need two random events to affect both sides, whereas if it's a genetic predisposition, then you are more easily affecting both sides. Bilateral clefts are also a lot harder to repair than unilateral clefts. The next picture there shows a midline or median cleft. That's a lot rarer, okay? Because in this case, rather than extending down from one of the nostrils, this cleft is extending down straight down the length of the philtrum. This kind of clefting is much more likely to be associated with some sort of syndrome, and in part because this kind of clefting can be an indication that, in fact, not just the cleft, but the entire head structure is not dividing properly into two halves. Okay, and when that happens in the brain, when the brain has not divided into two halves, that's a condition called holoprosencephaly. And many babies that have holoprosencephaly will have midline anomalies like a midline cleft or abnormalities of the nose, eyes that are closely set together. So a baby with a midline cleft is a baby that needs to be checked for underlying problems with the structure of the head and brain. The last example here has to do with section planes, and in this case we're looking at the coronal section plane, and we're talking about a birth defect called craniosynostosis. Now, at the head is formed, or the bones of the head are formed by these skull plates, which in a newborn are not fused together. Having those plates unfused makes it much easier for the baby to pass through the birth canal because the head can mold and shift in shape to allow it to pass through. But as the baby grows and ages into a child, a teenager, and adult, over time those sutures fuse. During early childhood, having some of them open allows for the growth of the brain, which is fairly rapid in childhood. If you've ever held a young baby, a newborn or very young baby, and felt the top of the baby's head, you may have felt what's called the soft spot, which is actually an opening called a fontanelle where multiple plates sort of come together. And of course, over time it closes. So what's being shown in this picture, if you look at the image of the skull, is that on the right side, the coronal suture, so coronal dividing front from back, is open as it should be, but on the left side, it's fused. And it's fused prematurely, which is going to affect the way that the skull can expand and grow with the growth of the brain. And this is the sort of birth defect that would usually be corrected.